Chalo. Very good morning, everybody. After this exciting session and a very exciting talk, we go on to a slightly more mundane but very common thing with lateral wall in proximal femur fractures. Why do we really bother about it, and what do we do about it? Why is because this is the only surface that we see per up. Don't see any other surface. And the most important muscles in the body, the abductors for walking, are attached there. All your fixations into the neck go through this surface, and your distal fixation starts from this. So all this is junctional area. It's like Katni junctions where all the trains arrive, and this junctional area is become very important now, and we have understood that if you don't address it, it is to our own risk. And this is the only reason is because this is one surface of the fracture that we see and we can do something about. Up to 2004, there wasn't much on this surface specifically, and then Gottfried brought it in his landmark article in CORR, saying that in his last series of patients he treated for trochanteric, unstable trochanteric fractures with DHS, 24 failed, and all 24 had some lateral wall dysfunction. Whether per-op he broke it or pre-op it was missed. So he brought out this term called the lateral wall. So what do we do with the lateral wall? If it's intact, you can use it to put your implant in, as we discussed. You can put a cerclage wiring. You can put a buttress plate. You can put a bypass with again a plate. But do not ignore it. So later on, as we come along later, this Chinese paper actually told us what exactly the lateral wall is. The first paper has told us regarding how thin or thick and exactly where it is. The lateral wall starts from the vastus lateralis ridge downwards and extends medially up to 20 millimeters. So any fracture within this zone makes the lateral wall very prone to breaking and later on instability. So if you haven't heard anything, this is the most important bit. 20 millimeter thickness of the lateral wall, and from the vastus lateral ridge down. You can look up this paper from China, which was the first paper which gave us a reliable predictor for post-operative lateral wall fractures depending on the anatomy. You have a good lateral wall like this with a little chip fracture on top, fix it with a DHS, bobs your uncle, patient does well. But then when you have fractures like these, the fracture running through the vastus lateralis ridge, the lateral wall being affected, very thin lateral wall, they need to be either buttressed with a plate or encirclaged with a wire. So I just go back history to my own practice. This is a case I did in 2005. I had not read Gottfried's article by that time. And after this I read Gottfried's article actually. Put a plate in, I thought, fantastic job, done a great job. But look what happens. Because I had not addressed the lateral wall at all, there was uncontrolled sliding. It slid, the limb shortened, luckily it united. If it did not, because the screw has got locked into the plate, it will start cutting out and the implant would have failed. Even although it has united, look at where the abductors are, look at the limb length. This chap is, every time he comes to my clinic, as a horror. He lurches, he's got short limb, he's moaning, so this is not the way to treat things. So I learned along the way, 2007, when I got this case, I added a DHS with a trochanteric stabilization plate. Along with the plate, I threw a wire. Nowadays, use a orthocord or a ethibond through the tendons at the attachment of the gluteus medius, which is tied through one of the holes in the plate, and if possible, another screw through the trochanteric stabilization plate. Now, this screw might not be given, but you need this lateral buttress along with the tie down of the gluteus medius. This goes on to uneventful healing with a bit of shortening, but at least that horrible collapse which was there does not happen here, and the abductors are retained well. Then came the nail 2009-10, and I thought, oh, it's proven, I don't have a problem. Just put the nail in. The nail will act as a lateral wall, but doesn't. As you see, this nail, the lateral wall is, as the fracture settles down, the lateral wall starts separating out. So something needs to be done with the lateral wall if it is there, even if you are nailing them. Now, if you are nailing them, to wire or not to wire. And this is a fracture, starts from the vascular ridge going all the way down. And if you leave it like this big gap is inviting disaster. So what ideally should be done is throw a minimally open I have done nothing. Please believe me. Was the talk so bad? Anyway, my spelling. Okay, it's fine. Sorry. So you need to do a minimal open reduction, put a wire through, and pass the nail. And sometimes the lateral wall breaks like this, so the whole lateral femur is completely off. And you should get these fragments together, put one at the most 2 wires, because it helps to get your nail down the right passage. Otherwise, your nail go in your hip will fall into varus. And this wiring construct actually gets the bony fragments together, so healing is much better. So you can put a long nail to bypass the fragments if you have wired these fragments. Plates, yes, you can use a plate like a distal femur locking plate of the opposite side or the proximal femur plate. Unfortunately, the proximal femur plates have come, so I'm a bit worried about them. I would rather put a DFLP to use as a bypass stress shielder. This is a case I borrowed from one of my colleagues, Dr. Sudesh Shah, who's got this lady from 2003 before Gottfried. He knew over the lateral wall, put a screw in, but the implant was not right. Failed. Put a blade plate. Unfortunately, that broke. Put a bigger blade plate. That broke. And then put a nail down. Look at the lateral wall. How it's disappearing. So this is iatrogenic. So you have gradually caused a shattering of the lateral wall till 2013 when the patient finally decided not to come back anymore. So iatrogenically, we can also cause a lateral wall dysfunction by these wrong implant surgeries. Sometimes we might be faced with a no lateral wall where the trochanter is split open with a failed implant, where we might be forced to use the nail as the lateral wall support. Although I do not like to use it, but since there's no lateral wall, we have to use this. Again, this is the last case I will show you. A nail also sometimes does fail. The nail broken, lateral wall split open, everything taken out, packed with bone graft and chronos, and what helps us? The DHS and TSP. And I feel that DHS and a TSP is a fantastic implant when there's a lateral wall dysfunction. So just run through a few articles. This is one of the first articles by Babst and Rana. DHS, TSP in lateral wall broken fractures does much better than just DHS alone. And then we get this run of papers in 2017 CCOT, where Dr. Gardegon, stabilization of lateral wall with a screw or a sarclage increases the stability of construct. Shows article. It's a must read on how to get away with avoiding pitfalls in very unstable fractures. And he's also devised a classification for this. And this lovely comparative study which compared nailing without wiring and nailing with wiring. And they found out nailing with wiring, the fracture healed faster, radiologically, functionally, it was better. Although it required slightly more, 15, I think it's 10 more minutes operating time, and the blood loss wasn't significant. So summary, lateral wall contributes to stability. It's just not the posterior medial corner. It contributes significantly, and we learned about it only the last 15 years. Our DHS and TSP with wires and screws is what I love to do best. But if I'm forced in a very low fracture, if I'm doing IM nailing, I would add a sarclage wiring to it. The wiring at the bone tendon interface has to go through the tendon bone interface. Don't try to take the bones because they split apart anyway. From wiring, I've gone on to putting orthocords or 5-ethibond. The reason being the wire sometimes breaks and the patient comes back, sir, what is that? That's broken. So if there's a little problem, there's a broken wire is a problem. So that's the reason it's more of a clinical, non-clinical that I've gone through. Thank you.
Thank you, Raju. Now I invite John or many.